Okay, thank you, everyone. The topic for today is breast cancer and social determinants. Obviously, breast cancer is not a new phenomenon. It's not a new disease. But I think sometimes when disease like breast cancer becomes an old topic, it seems to go away in the mind of a lot of people. And that's why I actually wanted us to have this discussion about breast cancer. And that's why I invited Dr. Teresa Ogidi Aleze, who also have a nonprofit organization, has done a lot of work with breast cancer, with different coalitions around the world, in Nigeria and other places around African continent, to talk about this particular topic. By the way, this particular program is sponsored by Resilience Coalition. And so we will be talking about breast cancer. Excuse me. Sorry. Okay. We have a little bit technical issue here with my phone. So that's why you heard the echo. But now I just fixed it. So I will introduce Dr. Ogidi Aleze. Okay, so a little bit about her and what she has done in the community. She is the founder and president of Associated Health Resource Center, Incorporated. This organization is a nonprofit organization. She dedicated to promoting and sustaining positive impact in society through the delivery of culturally appropriate, gender-specific, and targeted intervention to the most vulnerable population, which include veterans with PSTD, women health, pregnancy, and beyond, children, physically challenged, and elderly, and also people in prison or jail. She has served in various administrative positions with both state and local health departments in areas of HIV, AIDS, tobacco control, nurse educator, policy expert, servant leader, and advocate for transformational justice, who identifies and challenges structural racism and social strata as a root causes of health inequality and pervasive disparity in care and services. So this is just a summary of Dr. Teresa's portfolio. So without further ado, I will turn it over to Dr. Ogidi Aleze to give a shout out before I proceed with questions that I want us to discuss in this podcast. Thank you. Welcome back, Dr. Ogidi Aleze.
Thank you, Dr. Melo, and thank you everyone who have set aside time to be here. I'm truly, truly grateful to Dr. Melo to have put this together on a continuum. And we do know time is a non-renewable commodity. And for each one of you who is present at this event, I truly, truly thank you, because you have other things to do, but because of your interest and your mission to improve lives and quality, you've dedicated this present moment and hour to be with us today. I truly thank you all, and I thank everyone in my life to have enabled me one way or the other. And 98% of it are individuals that I never knew I would come in contact with, coming from a rural village in Africa, Nigeria specific, and the state, Rivers State, like Rivers, and the home area, Ekpe, located in the south region of Nigeria. And I am truly grateful for the work we have done. I won't say because I may have come up with the idea, but the inclusiveness of practitioners from all walks of life, they've made it possible for this program to be active and alive and to be sustained. And for the past 15 years, we've done a lot. And briefly, I shout out to a lot of our humanitarian philanthropists who, in one way or the other, had sponsored our trip on medical mission to many parts of Africa, and in some cases in one event or Haiti, and one other time to Brazil. I am truly, truly honored and to be in your midst. You all are experts, and I do believe in one thing. We have to learn from each other. And I always ask the question, are we there? It's my slogan for public health. So are we there? The question is yes or no. And some laudable achievement has occurred, while we still strive to do more and while we still want to improve in some area. Thank you, Dr. Melo.
Thank you so much. Thank you. So, a little bit summary of this idea of talking about breast cancer and social determinants in specifically in Nigeria, not just in Nigeria, but one state in Nigeria, which is called River State, is very rich in oil. It's part of the Niger Delta in Nigeria. That's where the most of the oil are coming from in Nigeria, and that's where most of the foreign oil companies are. And the part of the social determinants deals also with the idea of environmental safety. We know, based on literature, based on a lot of scientific university research, that certain petroleum, hydrocarbons, and other chemicals are known carcinogen. And we're going to dive into that. But before we dive into all the nuances of the risk factors of breast cancer or any other cancer or even chronic conditions, let me ask Dr. Ogidi Aleze about her areas of expertise. In other words, Doc, can you please describe your areas of expertise and how you started the work you are currently doing?
Well, to be brief about it, because I've engaged in a lot of areas, because my interest from childhood has been in the health area. Uh, as a typical 17 years old, I was in nursing school. And before 20, I completed my program. And while I was in the program, School of Nursing, Port Harcourt Teaching Hospital, I was fascinated with public health. Anything to do with community health, I was just very interested. And specifically, going through my program, I had to spend more time with community health, focusing on mother and child from get-go. That's as a 17 years old. So graduated and migrated to US at age of 22 plus. I was fortunate. I got into school to continue my education because you cannot practice no matter how good you are. You have to have a license in US. While waiting for transcript, I went into a university, Towson State University, completed my community health and healthcare administration, both masters and another undergrad. Then from there, I got a job with a local health department, Baltimore City Health Department, as HIV program coordinator, and later in 6 months as a manager, managing the fund and dealing with community agencies as sub vendors or sub guarantees. So I did that for 5 years. And after 5 years, I was transferred to go and repair tobacco control. Uh, it was a huge issue. That was through the master settlement of tobacco industry and the exposure with the blowout that there are over 4,000 chemicals added to tobacco, including formaldehyde, arsenic, things you would imagine. So it was a huge program. And during that venture, I was, because of my passion, I was elected as the secretary for Smoke Free Maryland for 4 years, whereby we travel outside US. We were sent to many parts of the world as US delegates to West Africa, to many parts, to create an avenue whereby while we're fighting the tobacco industry in US, they will not settle in a vulnerable region of the world, not just Africa, to go and create a tobacco farm, which we did. We found a lot of them, whereby a tobacco farmer will produce 50,000 worth of US dollars with a stipend of 5,000 per year. So we went to many parts, Senegal, Zimbabwe, with journalists from Canada. It was a big issue. And from then on, I enjoyed that. I came up with the slogan, smoking stops here. We still have the sign everywhere. I put a literature together, tobacco and pregnancy don't mix together. Secondhand smoke and asthma don't go together. To name but a few, not to wear you out. So I've enjoyed my work, and I've done a lot on advocacy. As secretary to Smoke Free Maryland, we shut down so many places in New York. As a part of legislation, we have to educate lawmakers. And we go on lobby day and push for cigarette taxes to be increased, and we did. In the state of Maryland, we got it to $4.99, just to deter people, or to deter marketing, distribution, and sale of tobacco product to minor or vulnerable population. And as we all know, HIV/AIDS, tobacco, every disease condition, they have inverse relationship. And as a result of that, we have to look at the distal factors and the proximal factor. Meaning, if you smoke cigarette, are you likely to engage in other, illicit drug? The answer is yes, because we have data and study that has demonstrated that. The other thing is, What about the risk factor associated with the use of substance abuse in any form or shape? Here comes HIV again. That's why the inverse relationship is so strong, because the individual who is shooting drugs through the vein, they are more likely to be infected with HIV/AIDS, and they are more likely to be engaged in illicit drug. So you can see the relationship that exists between these disease conditions. So we fought it, and to be kind with it, I enjoyed a position that I've been provided opportunity to serve in. And Philip Morris or the tobacco company will send me pack of cigarette to my door, meaning my residential, not even at my job. When we shut down a big firm in Atlanta, Georgia, they were marketing tobacco product to new babies or through water bottle, through feeding bottle, through beeps, in any way possible. And they tested it. It contains nicotine. And as we know, I know this is not the issue here. Why am I linking it? Because it has inverse relationship, exposure to tobacco, secondhand smoke or third-hand smoke, whatever we want to quantify it with the cancer, lung cancer, any form of cancer. I also teach in the past, health administration, public health, community health, ethical dimensions in health, just to name but a few, and some nursing students coming in, and some generally individual in the medical area who are coming in. Everybody more learn the basic and ethical issues in health, legal aspect of health, to name but a few. In a nutshell, I enjoyed my work. I love public health. I love to educate. I love community work. Regardless of the position I was in, I like to roll my sleeve and just go out there. Like now we're speaking, if not this today, I'm telling you, we have two major events going on in Baltimore City. We just line up the schedule throughout the entire year. This will be going through until second week of September or after Labor Day before we slow down. So I've done a lot in terms of policy. I've presented at the national level on three different topics. The number one is reach them where they are. That's HIV/AIDS. Number two, act locally. Think globally, act locally, meaning population health is dynamic, and we've all witnessed it with the pandemic. We may say, well, this is happening in China, but guess the massive pandemic effect that the whole world share. It was a shared disease burden at every country. So in my mind, okay, and I've been saying this all along, act locally, think globally. It's a very powerful thing. The pandemic of 2020 just pretty much enlightened my horizon, as well as, ignite more passion for me to do more in the area of public health. And I love teaching, like I said. Dr. Meru, I don't want to overburden you guys. I'm in coalition or partnership for cardiovascular health, asthma coalition, HIV/AIDS, American Heart Association, Star Path Hunger. With my agency was born out of passion because of women who are in impoverished communities, not just in Africa, but here in US, women in prison, men in prison with restrictive access to healthcare. So, they get back to the idea to create associated health resource center whereby we can go and educate these people, especially women in prison. People will say, how did they get pregnant? Or believe it or not, wide range of women are pregnant in prison. And how did that happen? I'm not going to go into that because that's not why we are here. But I'm linking how social determinant of health can be a contributing factor to other diseases that are acute, chronic, or just intermediary. An unattended situation could result to a whole lot of population health issue, which we are dealing with, including the epidemic and drug use across US and in other parts of the world, not just US. Because I just came back from a medical mission, and it's just devastating the world, and it's linked to HIV, causes cancer, and a whole lot of other things.
It's interesting because that's true. I was talking to a lot of scholars and some experts, and I say, we have a problem always thinking, there's areas now we started thinking multidimensional, but earlier it's just thinking linearly, right? So there's a lot of infectious diseases that we know now, communicable diseases that actually cause chronic conditions. And I agree with you. We need to start linking things, and we need to start having open mind about how these things happen. And we have to also open the opportunity for free thought, because I don't think even in academia now there are still restrictions about free thought. And because uh, scientific, real scientific work has already been infiltrated by politics, right? It's clear. But I'm not going to go there. That's a different topic. But I'm just saying, based on my own personal observation and based on my own also academic and scientific experience that I had. But I'm going to move forward to the topic of today and ask you about the problems of this breast cancer and social determinants as it relates to public health and epidemiologic perspective that you have observed, not just in the US, but in River State. Can you explain those to us?
Sure. Speaking of breast cancer, we all know, or we have known, or we may have heard, and we have seen or know someone, or relatives, friend, family member, that was diagnosed or has been diagnosed, or in whatever stage you find them in. So we all know that. And briefly, speaking of breast cancer, we know basically breast cancer is the most common form of cancer in women, and in United States and in many parts of the world. Deaths from breast cancer have declined in some area. However, it remains the second leading cause of cancer death among women overall, and the leading cause among some ethnic minorities. So, for instance, the Centers for Disease Control, quantify a lot of cancers, but more importantly, breast cancer is the leading cause for women. For instance, when we link social determinant of health, the facts are clear. Minority, for instance, Black American and Hispanic here in US, younger than 40 have higher incidence of breast cancer and lower survival rate than white. Reason for this is inequality or inequity in the difference or types of cancer that affect ethnic minorities. And, clearly 1 in 8 women will be diagnosed with breast cancer and their lifetime. And as we all know, we're talking about breast cancer now and linking it to social determinant of health. As we all know, social determinant of health is a group of factors that can result to adverse health effects if not addressed or if not attended to. Money in the bank, the type of work we work, where we live, our environment, the segregation, the ethnic minority. Where are we in things that affect humanity? So there are a host of other things, and the incidence is very clear. For instance, we have female in the 20s, 18.7% of death rate, and the incidence is 133.8%. So that's with adjusted rate. And we go into male or female, 18%, and they also account for stage distribution, meaning early, late, intermittent, or what have you. And 2017 to 2020, data reviewed 2 in 3 female breast cancer cases were diagnosed or at a localized stage, meaning the cancer had not spread outside the breast. About 1 in 4 female breast cancer were found at a regional stage of the cancer that has spread nearby lymph node tissues or organs, and in some cases ovarian, and 6% were found at a distant stage, meaning the cancer has spread to distant part of the body that were not very common. So as we can see, not to bore you with this data, this is active and alive, and it hasn't slowed down. And the reason majority of minority women found out about breast cancer very late. Sometimes it could be just a referral to go and see GY doctor or gastrointestinal or GI specialist. When they do some blood work or some diagnostic procedure, they find out. The unfortunate and troubling statistics is that a lot of these women found out at a very late stage, which is very, very late, and survival rate, they say 89 to 91% female breast cancer, had not died from their cancer in 5 years later because of modern medicine and improved technology has enabled this. But the question is why we enjoy this. This was 2020 data. Why we enjoy this year? Are we there yet? The question, can women in other countries, emerging countries, or if we call them developing countries, do they have access to this 89.9 to 91% survival in 5 years? No, the answer is no. I may not be very accurate because there are no surveillance in many parts of the developing world, like we are very fortunate to have data in the developing world. Because the stages of diagnosis overall is 91% in 5-year relative survival, localized 98.9, which I mentioned earlier, regional 86%. So with all this clearly stated, we can say that we are not there yet. We have unfinished business in terms of addressing breast cancer. And make no mistake, we also have about a good percentage of men who are diagnosed with breast cancer, which is not often discussed or even talked about. Because I went to a place last year when I was speaking, somebody's like, man, I say, yes, man. So a question came up. I say, give me a moment. I went to CDC website, men with breast cancer. Boom. I showed it, and a lady is like, oh my goodness, I'm glad I'm here. I thought it's just women. And that's locally here. And that's why I often say, think local, act locally, think globally. So the adverse effect of breast cancer is just humongous and insurmountable. So going to Africa, relatively, majority are not diagnosed because they have no access to testing and counseling. They have no access to pre-screening procedure. Mammogram, I will tell you, I paid for somebody on this trip that I just came back, equivalent of 200 US dollar per woman to have a mammogram in many parts of the world. Why? Because there are lack of investment by government or community, or lack of interest to invest in population health. And why we address the pathology, why we fail to address the pathology of these diseases, we want to mend and treat. And unfortunately, we have no known cure right now, although we have promising treatment in the area of chemotherapy. Kudos to that, a laudable public health achievement. But again, how many people can afford and access that even within US? And again, I recall this was just less than 2 weeks ago. Somebody was asked to pay a copay of $500. And I'm telling you, no name calling, her income was under 30,000 a year. The question is, are we there? Why not make it free? Why not facilitate process to afford access to these women to have quality breast cancer screening and treatment like those that do have the money? So in Africa, it's may I use the word kumbaya? Nothing in place, and they found out very late. Specifically, my home state, River State, in Nigeria, the South, predominantly oil producing state with more than 30 oil wells. Think of Shell Company, Exxon, Chevron, Total, almost all of them are in my home country, in my home state, particularly at my backyard. Shell has a pipeline that passed through my father's house. And that was before I was born. And my father's house was demolished. My father was fighting with Shell Oil Company till he died because he had no money. It's like David and Goliath fight. So not to say much about that, my father died fighting Shell. So you can see the social determinant of health and its psychosocial implication. And okay, thank you, Dr. Melu. That's a map of Nigeria. At the lower part of it, that's the South. That's River State, with the capital city being Port Harcourt. So that's major oil producing state in the Niger Delta region. And in my home area, with population, that's Ekpe in River State, with population of under 700,000 as of census 2010, we have calculated and confirmed 25 oil pipelines by major company from industrialized country. So the question is, are we there? No. Can they provide incentive to reduce the risk of exposure to environmental pollution? Because we have series of spills of oil. If the data is correct, I would say over 222,000 of gallons or liters of oil that leaks every year in my home state. It affects homeland, it affects farmland, it affects fishing, it affects everything. I would say, majority, I would say 60% predominantly were farmers and fishermen, because we are blessed with a lot of waters and major river that connects to the Atlantic Ocean. And majority were fishermen and fisherwomen, and women farm, and they sell local produce. So when you see the inverse relationship that exists between the resources that we have in River State and how devastated the people are living every day in poor and poorer, the poor among the poorest, it is just a high ranking. And for some of us that are here, we are blessed, and we try to go back and educate these women. And in light of this, I've dedicated my life and just go back twice a year wherever is needed and do a lot of talk, connecting health, not just breast cancer, exposure, pollution, water contaminant, they drinking the same water. I hate to say, I mean, no quantifiable data exists, but the most recent data from World Health, gives average lifespan for men in Nigeria 59 years old, 59 years, and for women 62 in 21st century, whereby we have advanced in technology and medication or modern medicine. Why is it still so? In a country or state like River State that is highly blessed with natural resources, but again, the rate of return, I said it, taxation without representation.
Actually,
Because
I think you are correct. Actually, the number about life expectancy is actually not correct. It's not your fault. The life expectancy in Nigeria is not even close to that number they gave. It's unfortunate, but that's the reality. They're just giving any number. When it comes to data, any data that comes out of Nigeria, many African countries, is not reliable. I can't even trust them. I mean, that's a different issue. I mean, that deals with corruption and inaction by the government to set up things to be able to have a standardized surveillance system to measure those. But I'm not going to go in really detailed diagnosis of why the numbers are wrong, but just for the sake of staying in topic, let's talk about the background basis of the work you're doing, or the one you have done already, specifically on breast cancer. And let's talk about not just the background of this work, but let's talk about the scope of the work in terms of the purpose and significance of the work. So we start with the background. In other words, there's a lot of people that has been trying to do this work and call attention to the oil pollutants in Nigeria that causes breast cancer, causes all type of cancer, and all adverse health outcomes. What was their fate? What has been done till now, 21st century, in terms of making changes and putting regulations together to mitigate the environmental and social adverse impacts of this spill that we have in petroleum in River State and other parts of the Nigeria and continent?
Well, thank you for that question. I think that's a deep-rooted question with a lot of troubling response that you will hear from me. The reason being that before even I was born, we have they've established a Shell pipeline in my hometown, more specifically in my family's homeland, without any compensation. And as a result of that, when I was very little, sometimes we will go to the fishing pond, we will see fish floating all over, and we'll say, what is killing all the fish? And there will be a lot of oil on top of the, just floating on the water. So then my parents would say, don't eat that fish, that's poisonous. But we as young people will say, oh, we found some fish because these are dead fish. So the question is there any representation with the resources they tap in? The answer is no. Do they even create a program or intervention to overhaul any spills in Nigeria? More specifically, in my hometown, Ekpe, the answer is no. Few years ago, Civil Reader, you can look it up, anyone can look it up. It was a global issue that drew Greenpeace, Amnesty International, World Health Organization. His name is Ken Saro-Wiwa, an activist, an advocate for social justice. He was hanged. I won't use the word killed. They hung him up. They hung him up. Ken Saro-Wiwa. They hung him up because of oil in Ogoniland. This is my home state. in the Niger Delta region. Why? He was fighting for the environmental pollution. He was fighting for the oil company to do the right thing, clean the water because the people are drinking from it. Him and 9 other people were killed because of indiscriminate petroleum waste dumping. He was silenced as they hanged him. They hung 9 others. It drew global attention. It led to other people killed, and it led to the movement that we call MOSOP, meaning Movement for the Survival of the Ogoni people. Even if Ogoni people were more specific, my area was adversely affected as well. But Ogoni people were named in this article because Ken Saro-Wiwa, late Ken Saro-Wiwa, was the one who led the movement, the nonviolent movement, because of the environmental degradation of the land and waters in Ogoni land. And believe it or not, it drew national attention, it drew all kinds of things. And again, this was by Royal Dutch Shell Company, and they still exist there without any taxation. Taxation, I use it several times here because the children have no seat in the classroom. There is no computer in the classroom. The children would faint in the classroom and die. When you compare to areas in the Middle East, Saudi Arabia, Kuwait, places that has, major oil production, that is contra. And the military tribunal just did what they did because of the influence of the Royal Dutch Shell Company on Ken Saro-Wiwa and 9 others. This was under dictatorship leadership then, Sani Abacha, the military individual who took over because he felt they overthrown the democratic process, that they felt that the country was not moving in the right direction. But again, he took over for atrocity and provoke international outrage and led to the Commonwealth nation calling for attention. So here you see Sani Abacha. Unfortunately, he's gone. Are we happy? No, I'm not happy. I'm not God. I can't. But again, he created so much trouble for us in the Niger Delta region, where I come from, and in my hometown, Ekpe in River State, and in Ogoni, where 9 people were hung. And we celebrate Ken Saro-Wiwa. I think the anniversary is coming up again, and we'll continue to celebrate. So as you can see, this is a lived experience. We're not telling you story. The people continue to live in this catastrophic and a very devastating environment. In 2022, it was complete chaos. We have flooding that measured, I'm not kidding you, look it up, measured 22 feet in some regions in my home state, because we are surrounded and bounded by the rivers, the Atlantic Ocean. The river overflowed, and it just devastated 54 villages out of 77. So you can see the death of Ken Saro-Wiwa is still very live and well in the minds of all of us that are from River State. And
it's not actually. I think I remember then. It was a very horrifying memory for me, even though I'm not from River State. Killing that man was very, very sad because I know it's the so-called government Abacha then murdered him and the other people, but I think there's also international play in his death because they stand by. Because I mean, you're fighting a multi-billion-dollar industry that's not only benefiting the United States, all these other global war powers. So it's like seeing him as a little rat trying to interfere with the process. And I think he was asking for a fair thing. Looking at the environmental pollution, I remember under Obama when oil spill happened in Gulf of Mexico. Every news was covering this. It's like nuclear bomb just dropped in the United States. I'm like, are you guys serious? Like, so, but I'm glad they did that because now you can overlay the oil spills happening in other places, how de minimis they look at it. Nobody covers it, nobody pays attention to this. So I think what's happening over there is not just a localized issue. This is a global issue. And there's a lot of people, a lot of countries that have their hands in what is happening. I'm not even going to go over to talk about what's happening now in Congo with Tesla and other stuff. That's the same mentality, the same pathology, that's happening. And who is covering it now? Nobody's is actually investigating those type of environmental issue, which most of those that are using children to dig all this stuff. And now what's going to happen with chronic condition. And I want people to understand this. Chronic condition is not like a bacteria, a virus that usually have short incubation time, meaning 3 days, 1 week. No, this is a long-term, incubation, a pile up on you for a very long time. And then in next 20 years, you might start seeing children in Congo. I just don't want to get off topic, but I'm trying to overlay the long-term impact of this type of stuff. 20 years, 15 years, 30 years, you start seeing a lot of population within that locality developing this type of chronic condition. But anyways, I'm going to hand it back over to you. Let's go deep and talk about the methodology or how you, while doing this job, went ahead in this area, collected the data about the cases of breast cancer or late stage of breast cancer that you collected in Nigeria. And let's also talk about your findings and social implications of your observation.
Okay, thank you, Dr. Melo. This is like I said, I try to keep and tune down my emotion because after the death of my father, I went on doing a whole lot in this area. Even if we do not have surveillance data, because of lack of funding and lack of government willing to invest into research, we have a lot of raw data that, if done correctly, can be translated into intervention research. But again, where is the funding? With what I do and my group, we do, is pretty much meet the community where they are. We organize a health fair, and this health fair is 100% free. We provide a screening. Sometimes we borrow sonogram machine from USA and travel with it, and we come back graciously. And when we get there, the women will line up. We will announce, look, we are coming, and believe it or not, it will not be only women from River State, it will be everywhere. And on this particular event,
hold on, Doc. I just want to warn everybody, the visual is gonna be really irritating, and perhaps very upsetting for people. So please bear with us because she has some pictures of the fairs and uh, intervention and awareness they do. For example, this is one of the women that have very bad spread of breast cancer. But I just want to give that warning before I share anything, please. Sorry about this
All right.
interruption.
No, that's fine. So part of what we do is community level engagement. We involve the community, meet them where they are. And when we do, we interview them, face-to-face interview. They tell their story. And in some cases, attend funerals of women who died from breast cancer. And, for those living the experience, family members will tell you what they went through. And in some cases, we'll have women like that picture you've seen there. That picture is a young lady who came at one of our events, and she said, "Oh, auntie, I need to show you something." And I said, "What?" She said, "Can I go to the bathroom with you?" And we did. And like I said, it's somehow emotional for me. And I said, "What have you done?" "Oh, no money." I thought it was a boy, meaning a staph infection. That's what, and I've been rubbing something. I'm quoting it the way they would say it to me. And I'm like, okay, this is beyond boy. How many years have you had it? Oh, it's going to 5 years now. But when you say, what is your age? I'm 28, I'm 29, I'm 32. None of these women on these slides, I think the oldest was 32 years old. Can you go while I'm talking on the slide, show one particular, go, this one. No, you passed it. No, go up. That's slide 20, 19. So again, like you said, please pardon the graphic nature of these cases. How old is this woman?
Are you asking me?
No, I'm just asking myself.
Oh, okay.
She's under 30, and you can see what she's going through. Even to attempt to even engage in surgical procedure is scary. Or these are photo voices. I don't need to say more. You can see what it is. On slide 22, at this very event, we saw a 9 years old then, and but now she's like 14, 15, who came not because she came to the health fair, because we assume young people are pretty strong and they don't have problem for healthcare, but they do. That's why a place like state of Maryland, we have adolescent health, and we are I am very, very grateful for creating, for the State Department of Health to create adolescent health. So this young lady came, followed the father who had a prostate cancer, and who felt that he can come and have a free surgical procedure done. And they did. We have surgeons who were excellent. They perform a lot of both invasive and non-invasive surgical procedure at this particular mission trip. So this young lady, while we are teaching breast self-examination, and she said, "Oh, auntie, oh, there's a little boy." I use the word boy because this is how they describe abnormal lump that they found. Oh, and I said, "How long?" "Oh, it's almost a year or two now." And I said, "Where?" So again, we went to an empty classroom because we use elementary school to accommodate more people. So we went to the place, and she took off her bra, and I touched it. And when I touched it, I didn't feel very good. And I said, "Okay." I said, "Raise your arm." She did. I said, "Touch it again." "Oh, it has grown." Long story short, I told her not to move, follow me. Then I went and talked to the father that we're going to attend to you. I've given your name. to the group that will have pre-op and everything. Your surgery is not going to be today because they have to prepare. You have to do some blood work before they can do any surgical procedure. A long story short, but at the same time, your daughter is not going to come with you today because we want to send her to do more examination and we want to perform sonogram. She said, oh, she's just a baby. I said, yes, but she has something she called boy. Long story short, after sonogram pre-screening, she had benign, non-malignant at that time. So we showed the test to the father. That was the following day when he was scheduled for his test. And that young girl, the father screamed, oh my goodness, this is the only daughter I have. So you mean to tell me my daughter would have died without me knowing she? How come a young girl like this will have a breast cancer? That leads to the question of genetic versus lifestyle. This is very young girl. Could it be genetic as associated risk factor? Could it be lifestyle? I don't know. But even if it's genetic, can we modify some of the behavior that predisposes individual with a known family history of breast cancer or any form of cancer? Yes, we can, by changing and adapting and adjusting our lifestyle. Thank goodness to this medical mission. This young girl had a surgical procedure done and 100% free, and she's well and alive today, and she's still contacting us. Or she graduated high school, or learning how to, as a beautician to fix women's hair, as well as provide, some cosmetics details. So you can see the work that I do. We have so many data, so many raw data, meaning that we don't need anybody to come and validate. These are real life people, real individual, real affected people, and they are living the experience. And some have died, and some are living with the experience as I'm speaking with you. So we've done a lot of awareness, education. What do I do each time? Teach one, reach one. In America, we have all this Every Woman Can. Should be a global initiative, which I'm very much aware by American Cancer Society here, and Susan Como. Where there is no coalition that lead a mission on breast cancer, not enough will be done. Again, my organization, Associated Health Resource Center, we organize a breast health examination. We educate women what to do. And believe it or not, and that's how we are coming up with more and more cases. As of today, I have total of 29 very ugly pictures. Some are not here because it's so bad that you look at it, you say, how did she survive? How is she making it? In one case, the left breast has stretched, the top part was eating up, stretch all the way to her lap. I've never seen anything like that. And when I brought the picture, showed it to a doctor at Johns Hopkins Hospital here in Baltimore, it's like, is she alive? I say, yes. Unfortunately, 2 years after that particular mission, I heard that she died. At that point in time, you ask the question, is it social determinant of health or what is it? The answer is yes. Why would a woman wait to progress to this late stage 4, stage 5? One commonality. I don't have money to go for the test. They asked me to bring so amount. But right now, because of the push we're pushing, they've standardized the price for breast mammogram. It's 50,000 naira. I mean, as of last month, I don't know if that will change because things goes up in Nigeria and never comes down. So 50,000. Can a woman who lives in less than $1 a day, equivalent, afford 50,000 naira? No. This leads to delay, pre-screening, diagnosis, talk about access to treatment. So the situation is emotional, and
then Doc, I just want to quantify or make a comparison of what 50,000 naira is. It's equivalent to like about $30, I think, around
yeah.
the area. Um, and also, even though there's right now in Nigeria, there's insurance. I don't know how well the insurance works, uh, but all this stuff is unfortunate that we're seeing. Again, it comes down to where there's a lot of social and economic barriers in care, specifically health care. But we also have upstream measures, right? And upstream measures is usually should focus on prevention. Now, we already know if somebody is genetically predisposed, that does not necessarily mean that that person will have the disease. There are so many things that can make somebody to have disease because gene itself will not just make somebody have the disease. It could be the environment. And again, whatever the environment is in terms of the risk factor for the condition you're talking about, you need to also look at the attributable impact and accumulation of those environmental factors or social factors. And here, specifically in River State, we know one big one, which is petroleum, oil spill that are actually disseminating and destroying all their agriculture. The plant is sucking up all these toxins and hydrocarbons. The underground water people drink is totally contaminated. The fish, the aquatic lifestyle. By the way, that's what most people in River State do. Their lifestyle is agriculture and fish and other stuff. So now I will want you to actually talk about the social implication in terms of the overall practical application of your observation. So, meaning you have observed all this stuff, the oil spill, the risk factors, the late stage diagnosis, and the cost of treatment, and even the cost of screening. So what are the public health, clinical, and community settings practical application to what you observe? What are the practical application to public health, clinical setting, and community settings? In terms of also, is there any policies that you know as of now in River State that is effective, enforceable in the state that is promoting environmental safety regulations and also promoting prevention and screening for breast cancer?
Well, thank you for that question. I will say, as we all know, not to hash on a social strata in Nigeria, more specifically in my home state, River State, are rich and blessed with resources and often dubbed as the hub of the nations. I would say no. The reason why I would say no, I met with the permanent secretary, Minister of Health, who happened to be a woman. And I say, Dr. Okay, Dr. This. And she said, yeah, oh, well, you all need to bring money. We'll put program in place. I said, bring money from where? Oh, from US. You have done a lot. Why don't you tell them to also bring money? So that I say, okay, do you all have budget? And she said, well, we have a lot of challenging issue. And I said to her, I'm not going to be upset. I'm not going to be angry. I'm not going to be disrespectful. Do you know somebody within your family circle, friend, relatives, who was or has been or died of breast cancer? Oh, of course I do. But what can I do? That was our response. And I say, as permanent secretary, and as a woman, why won't you push for investment with real money? Yes, we have policies and procedures in place in theory, but it's not in practice. Because it costs 90,000 naira to have one set of chemo. I paid for it. I paid for a brother of mine's wife. May her soul rest in peace. Her picture was omitted from this because it was just too much for me to look at her today. She passed away January 13, 2023. I paid for her chemotherapy, 90,000 per treatment. I paid 14 times. You multiply that, 90,000 naira times 14. You can see we're talking about millions. How many people can afford that? And by the time I knew about it, she was in stage 5. All we wanted to do was palliative care. So the answer is no, we do not have. But if you have the money, you can go to private clinic. And the question is, at what stage are they finding out that they have breast cancer? When they have no access to pre-diagnostic procedure, they have no access to anything that will link them, not even community awareness to increase breast self-examination. And this is why this is just a little emotional, passionate, disequilibrium in terms of disparity. I know we're not going to get to parity. Yes, the disparity is pervasive, lack of attention to invest in population health in the area of breast cancer, lack of interest to even see this as a problem. The money is not there. People are dying left and right. And I'm not kidding you. This year alone, I was notified of 5 women. And one of them happened to be one of this one in this picture. And I took one out. The reason I didn't include that one, I paid for it. Plus my brother's wife. The other woman was stage 3. My brother's wife was stage 4, stage 5. So the question is, do we have policy in place? Yes, in theory. Do we have clinical application of those policies translated to action? The answer is no. We have a teaching hospital. I went there, and I'll be raw with it. I created a lot of problems. And for lack of a better term, I shook up the place. And does it make any sense? And before I did that, I've been going to the chief oncologist, oh, there's no money. There's no money. That's what you keep hearing every day. But they do have budget. So practically, no. In theory, yes. They have it written down. But if you have action with talk without action, it's no good. And people are dying on a daily basis. And it shouldn't be that way. So engaging the community at the community level is critical. Breast self-exam, and again, having a sonogram in the villages with a trained practitioner to screen every single woman.
Thank you so much. And so let's stop right here and then open it up for open discussion among our participants today. But before that, I want to just give people some insight about River State. It's a population of less than 8 million people. We're talking about a state similar to maybe San Diego, right? So with what Dr. Ogudi Aleze just explained, each state in Nigeria receive annual budget every year from Fed. It's just also the reason about what she's talking about. I know that very well. The scope and level of corruption in political system, I know it's everywhere in the world, but the level it is in many of this African continent, based on also being infiltrated by mainly foreign interests, is alarming. And I think one of the solutions, not the only solution to this, will be creating more awareness and being honest to what is actually happening, and talking about it openly, maybe through this type of platform or any other platform, to be able to create awareness and having young people know about it, because the young people are the future of any nation. The more the young people take active action and participation in hot topics like this, controversial topic like this, that's better for any country. That's better for any community. That's better for any family. That's the reality of things. But we cannot continue living in 21st century with ignorance, with kind of like nonchalant attitude and dismissal of people's story. And that's one of the biggest things that happen often, like an individual or a community or a nation will tell their story, and then it becomes a political story instead of looking at it. Okay, let's either look at it at a logical perspective. Let's look at it at a scientific perspective and look at how we can provide solution. And that's what, in fact, my platform is all about. I want to, touch areas. I call it the road less traveled, right? I want to go to that road and then discuss the path of that road, and then bring awareness to what is happening on that road, and see if we can start making changes where it is necessary to make changes, upgrade things, and perhaps make that type of, maybe not macro, but maybe micro changes along the road. So with that being said, I'm gonna open this up for open discussion for our audience to have the opportunity to pose questions or make comments. It doesn't necessarily have to be a question. You can make comments and perhaps even propose recommendation on how to start solving this type of problems, or provide a solution to those. Thank you so much. And I'm going to turn it over to the audience. Anybody have any comments?
Yes.
Questions?
Yes, Dr. Romalo. It's William, Coach William Power up here in Canada.
Hey, William, go ahead.
Yes. Yeah, just coming a question, a very like a child question. I'm in Canada. Any woman here, person here, because we pay high taxes, We have free health care. But it's not free. We pay for it through taxes. But we have free health care. So anybody can go to the hospital, get checked, see a doctor anytime, get mammograms. Yet I don't hear success stories because they're being screened sooner than Nigerians. You know, I don't hear women, you know, I don't hear the success stories. So I question that theory that if people are screened sooner, that's just coming from a child mentality because I'm not an expert. And secondly, I personally don't trust the treatments myself. If I can stay away from a hospital here, even though it's free, I will, because of the pharmaceutical industry that I do not trust. Because everything I do, even though I'm you know, endorsed by Oxford and Harvard Medical School for my natural treatments for success, but you know, there's all kinds of things that they do that I question. I'm no expert, but if you know, we've been going on for a long time with this cancer thing, billions and trillions of money, it's big business, and I don't see results coming out of it. And you know, and just go back to the treatment thing. Any woman, man, child here can be treated right away and be diagnosed or be, you know, catch it early. And I don't see the difference really. So that's my comment. I just to stir up the thoughts for those in America that you need to pay or need to have insurance, and if you can't afford insurance, or even in Nigeria you can't afford the treatments, or, you know, does it really make a difference? I think the natural approach is still the best awareness, frankly. I'd like to be challenged on that. So that's my 2 Canadian cents, which is worth about maybe a half a cent. I should say half a cent American. So there you go.
Thank you for that comment. And I want people to participate in this comment. So the way I see this is for any health condition, right? You have screening part. Okay, before I go to screening, you have a whole package called prevention, which is usually upstream measure, right? The upstream, you have midstream and downstream. So the upstream measure involves prevention. Okay. Now, you come on the midstream level. That's where you probably have, you know, the screening part, where the insurance part will come in. If you have insurance and you have a particular way you live your lifestyle, you can catch up with a lot of screening. And then the downstream part is that you already have the disease, you screen, blah, 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 and you were diagnosed. Downstream, you're now going into treatment, right? So that's how I see this. Now, before even we go to midstream, and before even we go to downstream, what are we doing on the upstream? And that's where your comment might come in about, is this all about money? Because at the end of the day, if we already know the risk factors of many of these health conditions, why are we not spending a lot of money on prevention so that we don't even have to go into midstream? We don't even have to go spend a lot of time into the downstream level. And that's where that's how I look at this, you know. And for me, with River State specifically, what you can call the cradle of oil-rich so-called Nigeria, there should be the upstream level to monitor and regulate these oil companies, specifically foreign oil companies that just go in there and just do whatever they want to do, because nobody is regulating them, because many of the politicians are 1,010% corrupt, right? And that's where the issue is. I'm not saying this to say that the midstream level is insignificant. And I'm not saying that the downstream is insignificant. Whether the downstream part of treatment is through natural treatment or whatever else you do. Because if we can go to the source of this whole issue, like you see water coming out from the pipe, and you go to the source and close that tap, you might have a little bit dribble water coming out, but the majority of the problem has already been solved. So that's how I see this, and I don't know how you guys see it.
Teresa, I appreciate Dr. Williams and Dr. Mello. As we all know, the issue in many Africans or emerging or developing countries is poverty. Poverty on itself is a disease, and poverty of the mind is the worst form of disease because you don't have, you think nothing matters. My quest for associated health and any public health adventure is to increase the awareness. That's the upstream. To educate people, to ask people to take charge of themselves, to ask people to conduct breast self-examination, which, if done proper, effectively, it can lead to early detection without without the diagnostic stage of the midstream. Like the young girls I cited, without that health fair through our medical mission, I don't know what would have happened to her by now. She's now 14 years old. So that's one side of my statement. Then the second side of my statement is lack of interest for the government to invest in pre-diagnostic procedures or intervention. Everything I'm telling you, make no mistake, you can research associated health. No, everything is self-funded because of my passion for population health. You will not see any funding because funding is a public record. I work almost 3 jobs, but I'm not complaining. Just to make sure I give back. Have I applied for funding? Yes. In US, was I funded? The answer is no. Because even if I'm doing a lot here, no funding. So the question of sustainability becomes a challenge. How long would you continue doing it? That's one question. Should government provide incentives to provide massive education to the critical mass? Yes. Are they doing it in case of Rivers State? No. Must it be driven by the government? No. Community must own ownership. And where there is no engaged and organized organization like ours, we are doomed for failure. And that's why we see late stages. So prevention is still the key. That's the early phase. For those that will still have it, regardless of the education, whether genetic predisposition or risk lifestyles, yes, we deal with it. Then government comes in. Then the third level, the downstream. Now you have the disease. Can they still live an optimal level of wellness? Of course they can. Just because you have a disease condition doesn't mean you can achieve optimal level of wellness. But in these cases, each one of those photo voices, they do not have the opportunity. And I put it this way, living in communities where there are no medical facilities or trained medical practitioners. The alternative medicine, which I also believe in, I don't want to talk much about it. When I entered into PhD program, I thought about alternatives so much because of my late grandmother from my father's side, Patana. And I did 16 credit in alternative medicine. And I know exactly what you are referring to, Dr. Williams. But again, I will bring one thing that I do know. That's the sociocultural influence of health-seeking behavior. Majority of these women went alternative medicine first. That's why they will rub Vaseline, they will drink herbal tea. Yes, but it was too late. So can combination of Western by early diagnosis, once found out, then we go for alternative. It's possible, but we have to provide incentive for early diagnosis, screening, and linkages to care, whether alternative or not. But treating it blindly the way they're treating it because of cultural influence on health-seeking behavior tend to progress to stages 4 and 5, whereby we call it point of no return. Too advanced to do anything. Yes, I agree with you with alternative, but we must prevent.
Thank you so much. Thank
Well,
you.
I love your passion. I love your passion, and that passion will make a difference. And you're on the right track because, you know, our ancestors would, if they were listening to you, especially over in Africa, they had all kinds of natural magic, medicine and healing techniques, and it's been lost through the money people, and etc. So, yeah, thank you for pointing that out again. Thank you. Appreciate it.
Thank you.
Any other comments or question? I thought somebody just spoke. Okay, go ahead.
Yes, well, I need to inject a couple of things.
We can't hear you. We cannot hear you. Can you turn up your volume, please?
1 moment. I think my volume is on. Can you hear me now?
Yes. Make sure you're closer to the microphone.
Yes.
Okay, we're not hearing you. Is anybody else hearing him? Because I'm not.
No.
Okay.
Can you hear me?
Yes, I can hear you now.
Okay. There are 2 things that
Okay, we're not hearing you.
is it breaking up?
Whenever you speak now, I can hear you, but once you start speaking again, we can't hear you. I don't know what's going on with your mic. We're not hearing. Is there any other person that have any comment while Doc is looking to fix? Go ahead.
Yeah, I want to say something.
Go ahead.
Okay, my name is Precious also, and particularly I'm not a health person, but it's kind of interesting to, you know, to hear about these things and know how it's affecting the Black women and specifically how it's affecting people in Rivers State. I'm also from Rivers State, and so one of the Tina, it's just like a question in a way. You talked about the impact of oil exploration in River State and how it's more has like a causal effect on the breast cancer or any related disease or sickness whatsoever. So my question would be, do you have like a data to support the growth of more like a history curve that shows that, oh, at certain point in River State, maybe at the community level or at the state level, if we have reliable data, that it is the oil exploration that is probably part of why we have some of these things spreading. And if we have that, do we have comparative data from other states that shows that, okay, in River State we have this kind of pattern, and then in other states we are not seeing that? And so if we have these things, it kind of helps us to understand if actually it's the activities of the oil companies, releasing these harmful substance into the environment that are contributing to these public health related diseases and whatnot. So I would like to to hear that and see if we have. I know the problem of one of the major issues we have in Nigeria and is that we don't actually have reliable data, and so that might actually be a problem. But I'd like to hear from you to know if there is anything like that. So it helps us to understand the pattern of things. Thank you.
Dr. Mello, can I respond? Then I'll let you.
Go ahead. Go ahead.
All right. Thank you, Precious, for your insight. No, I will say we do not have surveillance data that we can rely on. And I will say that without reservation. And you may want to know why. Because of lack of interest by those in position and power to fund a research. Because we have the raw data. These pictures, 29 pictures that I do have in my possession, can be translated into intervention research. But do we have the venture, the funding? No, we do not have surveillance data. State-by-state comparison will make absolutely sense, especially people living in the Niger Delta region, River State in particular, Ekpe specifically, compared to somebody living in non-oil producing state. It's an appealing research, but no funding. The answer is we do not have a reflective answer because of lack of surveillance or data collection. The pollution in the Niger Delta area with all heavy metals. And I do believe you know a lot about mineral resources. You do understand, even if you are not specifically in the health area, that the inverse relationship with environmental pollution and mineral resources are major concerns, because a lot of mineral resources in your field of expertise, they are polluted because of pervasive exposure to a lot of these hydrocarbons or heavy metals. The question of reliability becomes an issue. The question of validity becomes an issue. The question of having a real data to support our photo voices become an issue. All boils down to lack of funding. A comparative data would be great. People living in certain area like my area, oil producing state, versus people who are in non-oil producing state. It's an inviting and appealing area to study, but there's no money. Thank you for that question and observation. Dr. Melu, I'll turn it back to you.
Yeah, so that's a brilliant question and deep thought question, because you can't just continue shooting in the dark and making statements. This actually was one of the paper I read for the preparation of this podcast, and this was published in 2023 by Ihu Oma Anyanwu and Etel. And I would advise any person that is attending this, take a picture of this screen, go on Google and look out for this article. Their conclusion is the findings suggest an urgent need for improved pollution control in the Niger Delta. Note that Rivers State is part of the Niger Delta, right? Taking into account the observed spatio-temporal variation and the exacerbation of effects in light of climate change, given the high level of contamination, further assessments of exposure effects and bioaccumulation in biota should include future climate change scenario and the effects on humans who intensively depend on the system for drinking water, food supply, and livelihood. The point here is that they actually looked at different areas in this area and look at all these so-called total petroleum hydrocarbons, heavy metals, and all this stuff coming from the direct effect of oil mining. And they also noted the increase in the what you call it, they did a gradient and looking at how these differ from areas where the oil is not being drilled. And you can see that clearly from this literature. So I agree with you. In terms of the study, we already know what the petroleum and oil contains. Go to World Health Organization, we know it's a carcinogen. But your point is very, very important, that there should be more regular studies or reports about looking, for example, going to the north, right? And looking at the north and see what is the level of these hydrocarbons and look at the incidence and prevalence of some of these diseases in those areas, and then look at the areas where these are mined. But also know that most of the times what had happened is that from the River State, they have a pipeline of oil going from this south area, when I showed the diagram, all the way to the north. But even though there will be oil spill in those areas, it will not be as intense as it will be where the oil is being drilled elsewhere. But overall, your point is well taken. And now the question is, who should I send? Who should do the work? And doing the work requires intense money. I'm talking about mad money. Money has to be really involved for researchers, university or individuals or group of alliances to continue doing the study and reporting it on regular basis. And the who shall I send phenomena is a problem in Nigeria in terms of government commitment. There's none. I mean, if I say there's none, maybe that could be a lie, but the level of commitment is probably very, very small. So the appeal is for us to create this awareness, and then maybe there could be a little bit pressure to the government to be able to take things into account and start implementing things that will make sense. Because right now, nothing is making sense. Why is there incidence of breast cancer like this? And there's not even standardized surveillance system. Talk less of this innovative approach that you just suggested to actually see the differences or see the gradient in terms of the location, regional areas. So I would say that's the best thing to do. But at the end of the day, we have to be realistic. You're from River State. If you know the system in Nigeria, you know how difficult it is to even uncorrupt these corrupt politicians. So that's where we are right now. And unfortunately, I don't think that it will be an easy fight. It has to be a group fight to get the change that we want to happen. So I'll leave it at that. Thank you so much for that amazing, innovative, and deep thought question and comment that you just made. George, are you now in sync with your microphone?
I'm trying to. Can you hear me now?
Go ahead. Well, if you can write your comment or suggestion in the comment box, I can read it, because there's something wrong with your mic. Where nobody's hearing you. I'm not hearing you.
I don't know what the problem.
Is there any person else that have any comments? I know we are way past the time for this scheduled podcast. Any other person here that have any suggestion or comment? Go ahead.
Yeah, hi. Thanks for the presentation at first. I still have the same question that was just touched right now, is the question of incidents. I understand you maybe cannot do comparison in Nigeria between states or different areas, but there should be data that talk about incidents in other countries, for example, in the United States, between different regions, between cities and farm areas. Can you comment about that? What I'm interested is really the basic level of incidence and not necessarily the level of care. I can understand more people will die if you're in a poor country where there is no care. But the first question for me is the level of incidence. How many women are susceptible to get cancer? And then if you have data, I don't know, between Norway, for example, and the Citome or something like that, it can tell you what are the effects, and then you can dig into social economic effects. Is my question clear?
Yes, I think Dr. Melo is searching for that, but while he's doing a research on that, in the past, I would have given you information, but I do like to be very clear when I provide facts and figures with supporting data. I didn't go into that, and there are tons and tons of information that will link that to some extent. The reason in the period that I was in tobacco control, we did a lot of comparison data according to region with high incidence and prevalence of lung cancer specific, ovarian cancer, and which is a common one, lung cancer, ovarian cancer, and one other cancer. Like Flint, Michigan. I don't know what part of the country you are in. We had a spill by the one of this company, a train wreck carrying a huge petroleum tank. They condemned the water. The government provided incentive immediately. The water was not, even if they say it was safe, but they took appropriate measures. And we had it in Louisiana oil spill, and they rise to the occasion to provide, a contingent intervention because it was a situational crisis. So there are data here in the state. I don't know if Dr. Melo is able to locate one.
Yeah, so that's a great question, Dr. Facchiotti. I think I'm highlighting a statement here from a publication. This is a statement from Environmental Protection Agency. There's, in California, for example, there's a study done, I don't remember the study offhand, that shows where California has stratified farm workers, where there's farms in California, and they were able to see the incidence and prevalence of cancer is higher among farmland areas. You know, people that are living in this area in California where there's macro production of crops in the area, because those areas use heavy pesticide and other stuff for their farming. And that's already been established. There's not even any doubt. But I will put that, when I find the article again, I'll put it in my website, either Resilience Coalition, Pahole website. You go to the resources, you will see the article. But what I was quickly able to pull up is that we already know there's a relationship between pesticide exposure and breast cancer. And both laboratory work has shown that, both quasi-experimental work has shown that, meaning where they do geolocations about geomapping, people, location of, which means identifying location of where people live, and then look at the incidence of certain type of disease, and then overlay it based on the pollution level metrics or indexes of maybe, you know, pesticides or anything that we already classify as carcinogen. So that work has already been done in different level in California, in the United States. Also, think about lead, when we know that lead is associated with a lot of adverse health conditions. And that's why Environmental Protection Agency promoted the, you know, eradication of lead in paint and other places. So those type of work is continuous and continue to go on. But right now, I cannot directly think out of my head to give you a specific literature, but I know there's a few studies done in California already about that same question you just posed.
Thank you.
Are you welcome?
Yeah, I just want to say one more thing.
Okay.
Okay, so thank you very much for the insights into my question. But one thing I also want to say is that so it makes a lot of sense that some of these things, some of these carcinogenic metals might actually be leaching. You know, if you look at it typically in a typical river state setting, you have more people in the rural area, and you know, they drink their water directly from wells.
Yes.
And some of these waters are not treated, and you know, this could be like a pointer. This could be like, you know, some of the sources that, you know, that could, you know, have this, you know, metals leaching, because, you know, in our groundwater study, there's what we call groundwater contamination, and we have a lot of dump sites. We have a lot of, you know, some of this effluent too coming from hydrocarbon activities, and they find their way into groundwater, and, you know, they leach into, and they get concentrated, you know, they become really harmful. And, you know, people don't treat these waters back home, and they just take it like that. So one thing again, I'm also very interested here is to look at if some of these pictures you showed are people who have lived all their life in, you know, in the villages, you know, in the rural area, and or if people who have stayed in the cities. what kind of, where do they take their water from? What actually is causing? Is it from the food or from the water? So these are some of the things that because I have lived well enough also in the rural area, so I know how the kind of things that that we typically take back home. We don't care about how, we believe that, that these things are just good, and we have a coping mechanism that we don't care. Maybe it's from a point of ignorance, or I don't know. We continue to take these things, and know over the years, these things get to a level that it becomes really harmful. And it's also part of the problem that we don't have a good health system that helps to check these things on time, and people, and I'm very sure that there are still a lot of women, a lot of them in their numbers, that they are living with this, breast cancer, that they don't even know that they have it. So it's a lot of problem. I have so many layers of issues to address here.
I totally agree with you, Precious. It's like multifaceted layers of problems.
Yeah.
But I don't know your area of expertise, but this is what I do know. I do know that underground water is, in fact, if you're into environmental science or anything, underground water is actually, everything being equal, is the purest and safest water to drink, in fact, right? Because in fact, the gravity and natural filtration of the groundwater, that's what it makes it very, very safe than surface water. Now, think about Nigeria as an example. Look at Nigeria. I remember before I came to the US, they used to have a water board, right, in each village that supplies the water. In many areas in Nigeria, that water board is not existent anymore. People build their houses, they do what? They have their own personal well all over. Now, think about that. If you are in an environment like River State, where in fact the oil pollution is leaching into the well, it's leaching into the rivers and everywhere, you are not safe. Drinking that type of water is not safe. But naturally, actually, anybody can look it up. Underground water is one of the safest water to drink than even the surface water. So that's a very, very good point that you made in terms of the type of water they drink, what location do they live, do they check all these petroleum hydrocarbons, and see at what quantity it is. You can boil the water, but it doesn't take these hydrocarbons away. What it would do, if there's virus and bacteria in there, and treat it, that will take care of that. But all these other heavy metals and all this stuff is still there. That's what you're drinking. And that's why I started making the statement at first. Let's understand that this disease we're talking about is not infectious disease, like has a short incubation time, like bacteria or virus, before it starts showing up. This is a cumulative long-term accumulation of all this toxin in your body, and without any exit area where it is being detoxified. People keep taking it, and 20 years, 15 years, they start showing these signs and symptoms of the condition in question. So there's a lot of work, and like you put it, there's layers of problems all over the whole place, and sometimes you become so infuriated because it's too much a problem that you don't even know where to start. But at the end of the day, we have to start somewhere, but the job has to be done with a multi-collaboration. It cannot be a work one person can be done. But again, if we always look at it at upstream, midstream, and downstream, and start working at each level, consecutively at the same time, we can get somewhere. George, are you now in sync with your mic?
Can you hear me now?
Yes, we can hear you now. Go ahead.
Okay. Thank you, Dr.
George, are you there?
Yeah. Thank you, Dr. Teresa. I can't pronounce your last name very well. I highly appreciate what you have presented. My additional contribution to our discussion is that other than water we are laying emphasis on, these pollutants in River State also include the soil and the air. So I think, and then to our government, they are quite aware about these pollutants for years. I mean, they led to a lot of crises in the 90s.
Yes.
I don't want to go into that, but these multinational corporations that are mining the oil have to be held responsible for some of these pollutants. It has been done before, but they should be able to contribute. Have you ever tried to apply, get them to give you some funding?
I will answer you very direct and very precise. I have tried. I sent a proposal to Shell that do have a huge pipeline in my own village before even I was born. They were interested, the narratives in the proposal, and what else? I laid out the scope of intervention from prevention, awareness, education, to those who were diagnosed or will be diagnosed because of associated risk factor or attributed factors. They acknowledge it, but I can tell you I submitted the exact same proposal, just changing the year and date, and they will not even respond to you. So you send email, they don't even write you back. You make a phone call, the person you spoke with today, maybe by the next 12 months, the person is no longer there. Yes, I had requested 3 times, and no, we will fund you. No, yes, we will fund you. No, we will not fund you. I've not had that. So after 3 years, I stopped. Then I went to Chevron. I specifically asked them to sponsor an event that I had planned to do in the entire state at one of the universities. It's called St. Ajoris University. It's a major university in Nigeria, in River State. I asked them to co-sponsor because when I ask for help, I don't specifically, often at time, say you must have to give me money. If you can contribute in kind, I'm okay with it, so long as the mission is achieved. And what do I mean by in kind? Can they assist us with the promotional flyers? Can they assist us with the printing of materials? Can they assist us with a canopy? Can they assist us to rent a sonogram? Can they assist us to pay the practitioner who will be performing the examination, the testing? I did all that. I requested in kind and I summed it up. This is how much it will cost. So I've done everything. So that's my nature. All I need is a problem to be solved. Whichever way it comes about, if you want to trust us and say, okay, I'm going to donate 10 Naira, $20, whatever it is, believe it or not, 100% of it will go into it. I'm spending my personal money. And that's why I said, look it up. You won't see any funding in what I'm discussing with you. Everything has been generous supporters from US. Like 1 year, AMA assisted us, 14 Americans, with myself being the only African to travel to Senegal, Dakar. And we are gracious to American Medical Association. So yes, I had done that, but after many years, you get tired. And at the time, the country wasn't this bad, but right now you have to have inside connection. And they say every politics is local. But if you don't have that higher power connection, nothing gets done. Even if you're doing the most tangible impact project, and our project is impact, make no mistake. Our project is impact. Because when you go to the environment and people ask you, when are you coming back? When are you doing this? Can you come to my village? can you come to my town? There's something about it. No funding. Yes, I had asked, but I haven't asked within the last 3-4 years since the pandemic, because I thought they would be interested to partner with us. No, they did not. And no
Thank you very much.
funding. Thank you so much.
Thank you, everyone. Thank you. Thank you. I do this because of you guys. I don't do it because I don't have anything to do. I know a lot of you guys have a lot of things to do. And but Pubholic platform is about supporting, facilitating healthy discussion for healthy people and for healthy environment. And that's where I connect with what Dr. Teresa Ogidi Alaeze is doing. I connected in the way that it's for healthy environment, it's for healthy community or healthy people, and then it's a safe place to have raw, unrestricted, evidence-based discussion and have people of like mind to discuss those. And then this will be posted obviously in my YouTube channel. So I'll make an appeal. If you haven't subscribed on my YouTube channel, please go ahead and subscribe. And this is the only way you can support this type of stuff, by subscribing, and not only subscribing, sharing the subscription to family members, colleagues, to ask them to subscribe as well. The more we share such information, the more we create the change that we deserve or we want. Now, every single one of us is very, very unique and lucky. We didn't come in this world by, an accident. We come in by probability. One sperm fertilized one egg, it happens to be you. As an individual, unique individual, the probability of that being you is heavy. It's very, very, big number of probability. So I think we should use the opportunity we have to promote healthy environment and healthy people and community. And this is one way to do it, through this platform I created. I will always look for the opportunity through Resilience Coalition or Pubholic to partner with any organization to promote public health, to promote environmental intervention and other stuff. So I'm really, really thankful to all of you guys to be here now. It's 2 hours. I scheduled this for only 1 hour. Thank you so much. I'm not going to hold you any longer. Thank you for being able to make out the time this Saturday to participate in this healthy discussion. And I hope you learned something today from this discussion. And I hope that you can share the knowledge, because knowledge is often not meant for you. It's meant for you to take it in and share. That's what knowledge, effective knowledge, is all about. It's not for you to take it in and keep it within yourself, but it's meant for you to take it in, think about it critically, rationally, and then disseminate that information. So without holding you further, thank you, everyone, and have a wonderful weekend and a productive weekend as well. Thank you. Dr. Melo signing out. And thank you, Dr. Teresa Ogidi Alaeze, for also the opportunity for you to come again in Pubholic to present this amazing work. Again, you are invited anytime to come here. If you have any updates, any new things that you want to share with the world, please let me know. And this place is your place as well. You can come in at any time to share information, and I'll hand it over to you. If you have any other shout out you want to give out to colleagues or people that supported you in this work, please go ahead before I close this.
All right. Thank you, Dr. Melo. And thank you, every one of you who stayed this late. Thank you so much. My shout out to every one of you. And I will end by saying that time is a non-renewable commodity. Every minute counts, every time counts. And for you to have been here, I appreciate you all. We have unfinished business. You pass it on. Thank you all so much.
Thank you, everyone. Thank you. And I'll be looking forward for the next podcast that's coming next month.
All right.
Thank you.
Appreciate you.
Thank you. Merci beaucoup.
Have a great weekend, everyone.
Dr. Mello, thank you for your time. Bye.
Bye. All right. Thank you so much. I'll let you go. Okay.
Yeah, I will talk to you later.
All right.
Okay.
Appreciate you.
Mhm.
Okay. Bye-bye.
Bye.